completed his residency in neurosurgery at Wake Forest University School of Medicine, his fellowship in pediatric neurosurgery at St. Louis Children's Hospital in St. Louis, Missouri, and he is currently a pediatric neurosurgeon at Brenner Children's Hospital with a special interest in pediatric brain injury. Please join me in welcoming Dr. Powers.
All right, can everybody hear me? Okay. Get a little bit closer. Is that good? Better? Okay. I love talks like that. I mean, how many people don't have kids in here? And how many people, so most of us have kids, how many people in that talk thought of ourselves as clinicians or parents? So I can tell you, I didn't, for a second thought of any of my patients. I was thinking all of my children. And so my disclaimer here, I have no professional affiliation with any, or financial disclaimer, but I am a parent, and I'm a parent of 4 kids who play sports. And really that, sorry to be so selfish, but that's really my interest in this, is my own children. I'm kidding, of course. I have patients too, but I've got 2 boys that play football. I've got another son who's not quite at football age. He's 14 months. And I've got a daughter who plays soccer and who wants to be a gymnast. So head injuries are something that are very just in my face all the time. And I've got more stories about that. So trauma is the leading cause of death in children older than a year. Traumatic brain injury is the leading cause of death and disability in children. Over 1 million head injuries a year occur in this country in persons younger than 17. And most of them don't get reported. And most of these kids frequently don't get help because the majority of them are in the form of what we're going to talk about mainly today, which are the mild form. Injury severity, I'm not sure how familiar everybody is with the Glasgow Coma Score, the GCS, but it's a scale of 3 to 15. In the hospital, we talk about GCS commonly, and we just use GCS and we give a number, and that is kind of a language that we all speak. GCS of 3 to 15 is the mild group. The moderate is 9 to 12, and the severe head injury is a GCS of 3 to 8. The GCS is made up of 3 entities, the eyes, a verbal, and a motor score. If the eyes are open spontaneously, or if they open, that gives us 4 points. If they open to us voice, so hey there. We'll talk to you later. If the eyes open to stimuli, so if I pinch my patient and the eyes open, I'll give that patient 2 points, and if they're just closed and won't open at all, they get 1 point. The verbal score is whether or not the patient can talk to me, so if I ask them where they are and who they are, I go ahead and give them 6 points, and so on and so forth. And that's really not part of the talk, but I just wanted to give a little introduction to GCS. So really, what is a concussion? That term we're going to use a lot today, and there are other terms, but I'll try to stick with concussion as the term that we're going to use for a mild traumatic brain injury. Why is there increased focus recently on concussions? If you look at the paper, if you're a frequent reader of the paper, or if you get on the internet and just Google search really anything, you'll come across some form of concussion news, research, or excitement in the media. Why or how are sports-related concussions treated, and what programs are available to prevent youth concussions? So I love this definition. This came out of a group of neurosurgeons, neurologists, pediatricians, family practice doctors, neuropsychologists that met in Prague a few years ago. They sat in a room and they tried to define what a concussion is. And just look at it. It's ridiculous. Complex pathophysiologic process affecting the brain. Wow. So they spent several days in Europe locked in a room to define a concussion. That's what we came up with. Induced by traumatic biomechanical forces. Yeah, it means nothing to me either. It's defined as any change in neurologic function. And that's really, I want to emphasize that. So 2 weeks ago, my son, who plays football, got hit in a game, and he had a very significant hit. I don't know who else played football, but he got ear hold. So that's when he's not looking, and another player came and literally hit him with his helmet right in his ear. And I knew right away, I'm standing on the sidelines, and everybody looks at me like, well, what are you going to do? And he's laying there, he's got his hands on his head. And I go over and check him out and everything. But he never had a change in neurologic function. So he had a headache, and we actually kept him out of school on Monday because of the headache, but he never lost consciousness, never had any memory difficulty, never had any dizziness, could remember everything, didn't have any change in his neurologic function in his sensorium. And so did he have a brain injury? Yeah, I think he had a brain injury. And I treated him like he had a concussion. However, according to our definition, that's not necessarily a concussion. And I'll talk about some of the limitations of this term and how we define these things, because according to our definitions, which, as I said from the outset, really aren't that great, he didn't have a concussion. Although I'm fairly confident that something happened to his brain because he had a headache for 3 days. CTs and MRIs are normal, and we'll talk about when the CT and the MRI is abnormal and what that means. And then sometimes patients can have symptoms that last over a year, and that's significant. So you'll have a patient that'll come to you, or one of your children. We can use the same paradigm that we talked about at the beginning. Let's think about our own kids in this situation. If you have an injury and your child still has symptoms for 3, 4, 5 months, and there's nothing that I can tell you is wrong because the CAT scan and the MRI is fine, that becomes very frustrating. I had a patient last year who fell on the basketball court who, after the game, couldn't remember what happened. Parents called me because friends of friends, and I said, well, why don't you come in and see me on Tuesday? By the time, and usually 90% of the times, those symptoms in someone who's not lost consciousness will be gone within 3 to 5 days. By Tuesday, after his game on Saturday, he couldn't read. And this was a 12-year-old who was an AAB student. He couldn't read. They put something in front of him, and he said, I don't know exactly what I'm looking at. This lasted for 3.5 months. And again, he's now reading, and he hasn't quite reached the level that he was last year in terms of his school function, but he's back in school, and he's able to read, and he's able to participate in school and everything, but it's something that I still don't know what happened to his brain, and that's what we're trying to find out. And I'm going to touch on a little bit of the research that we're doing. So the disturbance of brain function is related to, and these, let me just say with quotations, we don't know. So it's related to neurometabolic dysfunction rather than structural injury. I can't say that for certain because we haven't been able to identify what the exact place of injury is or the significance of the injury. It's typically associated with normal structural imaging findings, and it may or may not involve a loss of consciousness. So the brain, as everyone in here knows, sits within the skull, and it's surrounded by fluid, spinal fluids, the stuff that we take off when we do a lumbar puncture. It's essentially floating in there and bathed in that fluid, but when the skull hits something that's immovable, or in this case another helmet or whatever, the brain will continue moving until it stops within the inside of the skull. And that rotational force that's centered in the midbrain can cause the brain to be injured in several places. So it can be injured here as it continues to move after the skull stops up against the inside of the skull, and it'll also then hit the front of the brain, or hit the front of the skull, and then come back and be injured back here. Plus there's injury within here as the brain moves within the confines of the skull. And so just more definitions of concussion. Again, you can, if you go to the American Academy of Neurology, to the AANS, which is one of my national organizations, the American Academy of Pediatrics, we all have definitions of concussion. They're all a little bit different, but they all essentially say the same thing. There are 5 major features of concussion. Maybe due to a direct blow to the face, to the head, to the neck, anywhere that on the body that causes an impulsive force to the head. There's a rapid onset of short-lived impairment of neurologic function that resolves spontaneously. Again, that time period can be variable. It's usually within a short time period, but it can last weeks to months. And acute symptoms usually due to functional disturbance rather than structural injury. Again, we don't know that for certain. It results in graded set of clinical syndromes that may or may not involve loss of consciousness and typically associated with grossly normal imaging. So the names that we use to describe this: head injury, closed head injury, head trauma, minor head trauma. I like that one, a minor head trauma. Concussion, mild traumatic brain injury. Another one that I like is mild concussion. And I'll talk as to why that's a big misnomer, because the grading scales that we have don't really predict how long the symptoms are going to be or how severe the injury is. So to say that one is mild and one is severe is really incorrect. I would just say that they're all head injuries. Symptoms are variable, but they usually are all, the most common two are confusion and headache, certainly difficulty remembering or paying attention, balance problems, feeling sluggish. Fogginess is something that I always ask all of my patients after this, do you just feel dizzy or foggy? And that's a very common symptom in concussions that linger. So if you have any patients in which they describe fogginess, difficulty to pay, just not quite feeling right, that's something that will tell you that concussion is probably going to last for a while. There are several categories of symptomatology: physical, cognitive, emotional, and sleep. And again, this fogginess is one that we, in particular, that's one that I think that once we figure out what the anatomical substrate, meaning where in the brain causes the fogginess, that will allow us to predict better as far as how long the concussion is going to be, how severe, and what long-term consequences will ensue. Most athletes will be fully recovered after 21 days. It should be 90%. Takes longer if you have a history of headaches, depression, ADD, certainly a family history of migraines will lead patients to have longer symptoms of headache. And then once you've had one concussion, you're more likely to have another. That's been shown, and it's actually more common the younger you have a concussion, the more likely it is you are to have another. Here's the full tally on sports-related brain injuries. Now, this is not just children, it's adults. Cycling. Does anybody know the number that putting a well-fitting helmet on a cyclist with a strap underneath, how much does that decrease your risk of a head injury? 85. Beautiful, yes, 85. That's an amazing number, So 2 weeks ago, a friend of my son's falls, hits his head, passes out. His friend is with him. He's on a skateboard. They call the ambulance because he's out and can't remember anything. He now has blood start coming out of his ear. And the ambulance picks him up and brings him to the hospital. I was actually out of town, and I got a call about it, and I said, okay, I'll see him on Monday. And the person who's on call took care of him. And everywhere in his medical record, this patient was helmeted. He was helmeted. He was helmeted. There were like 4 or 5 things that helmeted. What's the one question that they didn't ask? The strap. So I walked in, and I know this kid. I said, Michael, you didn't have your strap on, did you? He's like, no. And I had to go back and tell the residents, and I said, look, that's the most important thing is the strap. You can have a helmet on, but that it'll fall right off. And so likely if he had his strap buckled and if it was a well-fitting helmet, my guess is he would not have been admitted to the hospital for a basilar skull fracture and a spinal fluid leak and a subarachnoid hemorrhage, but he did. It's a tough lesson to learn. So helmets are great, but they need to be well-fitting and they need to have a buckle underneath them. Did you see that? On the bottom. Concussion rates in high school sports. Football obviously has the highest. It is a deliberate contact sport. These numbers, interestingly, and it's something that I think we should look at, is adjusting these numbers for for the participants. Because I think, if we look at the number of kids that play these sports related to the number of concussions, I think these numbers will be different. Because I think, especially this one, if you notice, girls basketball is higher than boys basketball. Girls soccer is higher than, it's actually not. These two should be different. My point is, girls have a lower threshold for concussion. We don't know why that is. Playing similar sports, they will develop concussions easier and with smaller force blows. And that's captured in this slide here. Girls competing in soccer and basketball are more susceptible to concussions than boys are. We don't know why that is, and I actually have not heard a single thought as to why that is, but you can just put that in the back of your brain. I thought this is an interesting slide. So the black bars are contact with another person playing the game. The gray is contact with the equipment, and the white is contact with the playing surface. Most concussions in basketball are when the player usually will trip and hit their head on the wood floor. Obviously, baseball and softball, there's equipment there that can potentially hurt one, meaning the bat. Whenever you see a slide like this, it's meant for you not to read because there's too many words on it and the font's too small. And so it's a teaching point for several reasons. One, concussion grades we use them and we talk about them. However, they're not uniform and they're not accepted because we have yet to find a grading system should be able to tell us how long the symptoms are going to last and also a prognosis, right? Well, right now, a grade 1, 2, and 3 concussion don't tell us any of that. And so that's why these grading scales, and there's several of them out there, are not widely used. And so that's why you'll hear NFL coaches, if there was a grading scale, we would use that terminology. However, now they still use terms like mild concussion. Again, those things don't give us any information with regards to symptomatology, prognosis, or treatment. The acute concussion evaluation is a clinical tool that we use here that not only allows us to diagnose a concussion, but also gives us information with regards to return to school and return to play. And let me just take a step back here. So I'm going to be discussing several different things, and there's two. When you're taking care of a child with a concussion, there's two important things that you need to keep in the back of your mind. One is return to school, and the other is return to play. Even if they don't play an organized sport, you should think of both of those in every child, unless the child is a complete couch potato, which some of them are. And in that case, you need to counsel them on the importance of getting out and being physically fit. But you need to think of, and when I say return to play, it's just return to playful activity. Not only playing, soccer or whatever sport they play, but just going out and playing. So, and when I say playing, that's going out riding a bike, riding a skateboard, being active with their friends, climbing on monkey bars. So the ACE takes into account injury characteristics, has a symptom checklist. You can get these online. And if anybody wants, you can send me an email. I think these slides are going to be available. Are they online? But if you can't find the ACE, just send me an email and I'll send you the link. But these are free, and you can download the PDFs. It looks like this. There's a office visit version. There's also a sideline version that PTs and any sideline clinicians can take in terms of, or can do right there on the spot and diagnose a concussion. This is a question that I get frequently. When should someone get a CAT scan or an MRI? So you get a call, your neighbor's child fell. Should I take them in? And that's a very difficult question. We're going to go more into it as we talk more about moderate to severe head injuries and skull fractures and spinal fluid leaks and intracranial hematomas. But when should we get a CAT scan? And I can tell you that there are factors here. Now, this data was not collected just in children, but we can apply it to children, certainly age greater than 65 gives us that. But the best predictor of whether or not we should get a CAT scan is signs of basilar skull fracture. So you guys remember Battle's sign, which is a bruising behind the ear, the raccoon's eyes when they have bruising behind their eyes. Those are indicators that someone should go get a CAT scan. I would say if you're at all concerned and think that the patient needs a CAT scan, get a CAT scan, or at least send them in to be evaluated at the hospital. If there's a question at all, have them go in. So concussions, again, since we don't know where the injury is, we don't know in terms of its anatomy, we don't know the extent of injury with regards to the brain, our treatments really are just based on the tincture of time. So physical and cognitive rest are the mainstays of treatment of concussion. So we want to refrain from strenuous aerobic activities. We want to refrain from really any activity. I'll tell patients they can walk. They can't go to the mall and walk, but they can walk around the house, and that's about it. Cognitive rest means cognitive rest. So can you read a book in cognitive rest? No. Can you watch TV? Can you play video games? Can you text? Can you do any of that stuff? No. And remarkably, kids with a concussion will actually do this. So that particular kid who actually didn't have a concussion, he had an intracranial injury, but you treat them the same way. He's been doing cognitive rest for the last 2 weeks. Saw him just yesterday. He's doing much better, but if you ask his mom, she said, well, I thought you were crazy when you said he can't do any of this stuff. And if they have a brain injury, they will. I mean, they will just chill out, and that's the point. They need to chill out. Recommendations are based on the best available science, and I put this last point in that kids don't die in the middle of their sleep from concussions. And so I want to kind of demystify the whole we need to wake the kid up every 2 hours and check their pupils. One, I think that's a scary thing to send parents home with. How many in here have ever told parents to do that? Yeah, so I mean, it's still done because I'll get calls and they say, yeah, that the nurse told me to wake them up every 2 hours. What am I supposed to look for? Well, one, it's hard to wake kids up in the morning. I mean, it's hard to wake me up. And it's hard to wake kids up every 2 hours. Number two, I think parents are not good evaluators of the pupillary exam. Three, kids don't die in the middle of sleep of concussion. And so if you educate the parents and yourself on how to diagnose a concussion properly, no one has ever gone home and died from this. Now, the thing that people do go home and die from, there's one thing, and we'll talk about it, is epidural hematoma. And that's a totally different entity, different diagnosis, different set of circumstances that we'll talk about to differentiate. There are neuropsychological effects of concussion, certainly attention and concentration, the working memory, and we have ways of testing this. New learning and memory is difficult in these kids, and that's another reason why we make them or treat them with cognitive rest, speed of processing information, and reaction time. So if I can stress cognitive rest anymore, this slide should do it. If you look at the percent reporting symptoms worsening, so 87% of patients who did not listen to their doctor and did not heed their advice of cognitive rest had worsening of symptoms, as opposed to 37% who went out and ran around. It's just that's an amazing number to me. The cognitive exertion is again, I can't emphasize it enough. This is 3 weeks out, first week, second week, third week. So still close to 50% of patients at 3 weeks out, if they start to get back into playing video games, watching TV, reading, they will have symptoms exacerbation after their concussion. We do have new assessment methods for following their neuropsychological status, their computerized testing. This is a pretty neat thing. How many people have heard of the impact test? It's a neuropsych. It's a quick neuropsych test that's used a lot in sports. You take a preseason test, and then during the season, if one has a concussion, that patient takes the test within a week, and the decrease in the score will tell you how much of a decrease in overall cognitive function there is, and you take subsequent tests to make sure that the patient comes back to baseline. Well, that test has been approved for kids 12 years of age and older. There's a new one, the Pediatric impact test, that will be released hopefully, they say January, but we're testing the beta version here in our concussion study that we're going to you'll hear a little bit about today. So the acute concussion evaluation that I showed you, there is a care plan that goes along with it. So there's that assessment tool that allows you to diagnose the concussion, and then there is a care plan. Again, you can download these PDFs and use them, and here's that. And so, again, you fill out the information, and this will essentially guide you on returning to daily activities, returning to school, and returning to sports. Keys to recovery are resting the brain and getting good sleep. Certainly no additional forces, so keep the patient off of, I think I get the question, can my child sleep in a bunk bed? I think that's fine, unless they're prone to fall out of it. Managing and facilitating physiologic recovery. So we want to avoid those activities that produce symptoms, i.e. reading and cognitive processing, and then not overexerting the body or the brain. Return to play criteria are pretty complicated these days in terms of the high-end elite athlete. Those of you who follow sports, that a patient or a player will get injured on Sunday, and there'll be several days of in the news whether or not that player is going to get back to playing on the next Sunday, because all the fantasy owners want to know. It can be very sophisticated on their end, or at least what they think. On our end, taking care of the Pop Warner player, taking care of the soccer player, we want to see them no longer have symptoms. We want their neurocognitive function to be normal. We want them to be able to go to school without headaches. So we want to do this in a very stepwise fashion. We want to clear them for school first before they go back to play. That's something that parents have a hard time understanding. Well, can he go to practice even though he didn't go to school? No, he's got to be back to school. He's got to be able to sit through class all day, not a half day, but a full day. And then they need to go back to not going back to playing full time. They need to go back and actually try to jog some, and then go back and play a little bit, and then go back to play. So that whole process can take weeks, and it's your responsibility to guide it. When in doubt, sit them out. So that's the easiest thing. Very rarely will I give medications to treat a concussion, but prolonged symptoms, which certainly include headache, sleep, attention, and mood difficulties, I have given antidepressants for teenage kids who've had mood-type symptoms after their concussion. And that's months later, in which I've known that they've returned to school and they've returned to playing, but they're still having issues with their mood. I've given antidepressants for. Difficulties in taking care of concussions, certainly there's underreporting of symptoms, there's poor recognition of symptoms, there's intentional avoidance of my own son, who is sitting there with a headache, and he says, I want to go back and play. This is just last week. I'm like, no, you have a headache, Well, no, I don't. Well, why is the ibuprofen in your bedroom? And certainly coach and parental pressures. I told a child that he can't play football anymore because of an injury he sustained, and he proceeded to punch a wall in the clinic office, and his dad passed out and started having a seizure. And mom put her head between her legs and was screaming. Now this scene in my office was amazing. It is funny, but we all have to take a step back and say, are you serious? But yes, it was like the carnage that was, and I just walked out. I was like, can we get some help in here? Because I can't. And it was as if I told them, that their son, he had to go away forever. But I actually just said, you can't play football. And the son was a sophomore, and he plays baseball. And I said, there's other great things to do, but obviously parents take an active role in their kids' athletics. There are locker room posters that are available. You can actually get these for free. And again, if anybody wants these or has wants to put them up at their school or their church, send me an email and I can give you the link. This one was produced by the AANS and the CDC. Future directions, certainly new game rules have already started. Some research that came out of Virginia Tech with the collaborators that we work with in our study published a paper in March. And before the season started in August, Pop Warner International changed their rules around because of that. And I'm going to touch on that. So I think that's pretty cool. NFL is changing their rules around. They moved the kickoff line up. My guess is there will be a day when there will be no more kickoffs in football, if there will be football at all. So, it's a great game. I love playing it. My sons love playing it. But if we can't make it safe for everybody, then it may not be a game that we should play. Certainly new equipment and genetic and biomarkers. So things like you have to take a blood test before you go play this sport because you may be susceptible to a particular type of head injury, more so than the player next to you. Again, concussions are huge right now in the media. I just Googled this, and 20,000 hits in the news section. So that's all the relevant news within the last couple of days came up over concussions. There's roughly 3 million sports-related concussions a year. Again, that's in adults and kids, but they're very common in youth sports. And I get this question a lot. I talk to coaches, high school coaches, Pop Warner coaches, soccer coaches, and they all ask the same thing, which is, are concussions on the rise, or is it that we know about them more and are oversensitive to them? And I would say it's both. I would say that certainly our understanding is better, and our ability to diagnose them is better. There's recent media reports highlight the potential but rare catastrophic outcomes. People dying on the football field is a real thing. And legislative efforts such as the lifestyle laws out in Washington. Does anybody know what these laws are? So they're named after, I've got a slide of him. The lifestyle laws came out in 2005 in Washington State that say that if a player is suspected of having concussion, he's got to come off the field. He cannot return to the game and has to be, before he goes back and plays again, even practices again, he's got to be cleared by a medical professional. There are still 19 states in the country that have not passed similar legislation. In North Carolina, we have that law, so it's a good thing. Youth sports are inspired by Collegiate National League sports. And again, there's increased in reporting concussions in the NFL, not only in youth sports, but in the NFL. And they have a similar lifestyle rule in the NFL. And really, this is the thing that has kind of been thrown up on the wall and has garnered the most attention is the chronic traumatic encephalopathy. And again, this is a pediatric conference, but I put this out there and want to talk about it because we don't know when these players, when the seeds of chronic traumatic encephalopathy have been sown. A lot of these players, they didn't just wake up and go through their normal adolescence and young adulthood and then start playing the NFL. They started playing football as kids. And, part of the research that we're doing is trying to figure out, is that exposure playing as a child, does that create the start of CTE, or is it that exposure as an NFL player? And I would guess that it might be due to their exposure as kids. It might be due to their exposures as teenagers. I'm going to show you a slide of the brain as it evolves, but there is, he talked about why adolescents make some of these decisions. There is an organic reason why they're crazy. It's not a secret. So as we develop the blood flow to our brain increases continually until we get to adolescence, and there's a sharp spike down. Okay, and then it levels off. And so nowhere in our lifespan does the blood flow to our brain drop so dramatically than in those 2 years of adolescence. And during that time, so you get this drop in blood flow. During the same time, the number of connections that the axon, so the brain is a series of internal connections between all these cell bodies, right? So let's say we have 1 million of those. Well, during adolescence, during that drop in blood flow, the number of those connections drops by several fold. It's called synaptic pruning. What we think is happening is that the brain is becoming more efficient. But during that period of time, obviously, the patient, the person, the adolescent is crazy. I mean, they're insane. You talk to any parent, you know, we joke about that, but it's true. And I think about, you know, the behavior that I showed when I was that age, and I think, why did I make those decisions? Well, now I have an excuse. And it makes sense because everybody uniformly goes through it. I mean, not every kid, you know, goes off and colors their hair and, you know, runs away and does that kind of stuff. But every adolescent goes through a period of their brain changing in a way that's totally different than any time they'll ever experience again in their life. And so yeah, it's just puberty. So the 2 years. So it's easier in a girl because as soon as periods start, that's when it starts. So from that day, from the onset of menses, 2 years after that, that's when that window of time is. And so this slide, these are the guys who have been diagnosed with chronic traumatic encephalopathy. This guy here, Junior Seau, recently killed himself. It's only diagnosed at autopsy, so you have to get the brain, you have to cut it, you have to stain it. He has not been diagnosed, but I'll bet anybody in here, if they'd like, that he'll have this CT phenomenon. Neurodegenerative, what's that? Yeah, exactly. There's no chin strap here. So I put this on. So Alzheimer's disease and ALS is 4 times higher if you played in the NFL than if you didn't. Now, this has not been looked at in collegiate players or in high school players. They just first looked at NFL players. And my guess is it probably is higher in men who have played the game for some certain amount of time. Doesn't necessarily have to be the NFL. This is just to show you that concussions really from the NFL standpoint have not even been on the map until 2002. So we're kind of in the era of, hey, something's happening here to these guys and we need to figure out what's going on. So the science of concussion, the science of concussion really is kind of a misnomer because there is not a whole lot behind it. And that's one of the reasons why I joined with several of the guys here, guys and women, to try to figure out what is happening to the brain. So there's no MRI or CT evidence of injury. We don't really know the biomechanical factors involved, and we're trying to figure that out right now. How do we measure the impacts that the brain is subjected to? Where in the brain and what in the brain is injured? Are they reversible or irreversible? What are the factors that determine symptom severity and recovery? And then what are the injuries that are responsible for CTE? And again, we have no answers for these yet. So a few years ago, a biomedical engineer took 31 hits in NFL players that were known to produce a concussion. He then went back to the lab after looking at TV data and figured out the speeds that the players and the angles to which the players were hitting each other, and then recapitulated those with dummies and found that the necessary linear acceleration to produce a concussion was 79 G. And so for a while, we believed that was the number. So that's 79 times the force of gravity imparted on the head. That was the number that people quoted as the kind of the threshold to create a concussion. And work that's been done at Virginia Tech by our collaborators there in which they began placing accelerometers. So these are sensors that measure the force of impact of each hit. Has kind of debunked that notion that 79 Gs, if that's reached, that a concussion will be created. And so this is just to show that over 150,000 hits have been collected by this data set, and there's several universities that currently have these accelerometers in their head. We've never put accelerometers in the heads of youth players, though. High school players have just started, but youth players, we haven't. And so you'll see this slide again in the next talk when they talk more about the biomechanics of head injury. But really, we don't have a whole lot of data on pediatric brain biomechanics. And so this study was performed in the fall of 2011, instrumented 7 children. 495 impacts were collected, and you can see there were 8 hits above 50 Gs, in that range of potentially producing concussion. And these are in 7 and 8-year-old kids, and that's pretty amazing. And all these hits were found in one particular drill in practice, not even in games. And so that's where Pop Warner International came after reading this paper and said, we need to change our practice patterns. We need to change and get rid of this drill. Does anybody know the name of the drill? The Oklahoma drill? It's where every football player who's ever played hates that drill. It's torture. So our study here, we're basically instrumenting kids from 6 to 18. We've got 2 teams in the youth football age groups here in Winston-Salem, and then 1 high school team, Reagan High School. And then up in Blacksburg, Virginia, there are 3 football teams as well. We are performing MRIs and magnetoencephalograms on all the children prior to the season, if they have an injury during the season, and after the season. If they're 12, we've given them the impact test, or we've given them the pediatric impact if they're under 12. And hopefully we'll be able to identify, using the data collected in practice and in games and the structural imaging data, hopefully be able to identify where the brain is injured, what's injured, and how significant what that means. And so how can you help minimize risk factors in sports concussions? And so certainly teaching safe techniques in practice, encourage recognition reporting, take the time to go out and learn what sports your patients are playing, take an active role in that. Ask them, do your coaches know anything about concussions? And I can tell you not all of them do. Some coaches do, some coaches don't. Use the available assessment tools that you have. If there are any questions that you have after this, email me. My email should be on the, we can get it to you. But these assessment tools are free and downloadable from the internet. Be extra vigilant with your younger players who are more likely to be injured. We don't have to encourage the passage of lifestyle laws because we have those here. And then, so here's the epidural hematoma. This is the classic fall down, hit your head, wake up, you're fine, and then we call that the lucid interval, and then you pass out again, and that's when the bad stuff starts to happen after that second time you pass out, and potentially death is an endpoint with that. I'll tell you a little story. When I was a resident, a kid went in for his 18th birthday to Claire's boutique in the mall. I tell this because my daughter was at Claire's yesterday. And he had his ear pierced. And after he got his ear pierced, he stood up and he had a vasovagal response and fell down and had an unbroken fall and hit his head. And of course he passed out, and it was a big commotion. And they called the EMTs. By the time the EMTs got there, he woke up. He was fine. And he said, I'm okay. I'm going to go over to the subway. And the subway that's just right down there, just as you're exiting the mall. He got a sandwich and went home and told his mom, I'm going to go to bed. It's 10 o'clock. And his mom thought, well, that's kind of strange, on his birthday. His mom ended up going in and waking him up at 2, or trying to wake him up. She just had the wherewithal to do that. Of course, she couldn't wake him up and called the ambulance. They came, brought him to the hospital, had a CT scan very similar to this. And they called me. I was the neurosurgery resident. I come down to the emergency room. I see this scan. I said, "Oh, we got to take him to the OR." And we're like dragging. I'm actually wheeling the gurney up to the operating room, and the same EMTs that saw him in Claire's are walking by, and they're like, "Hey, we just saw that kid 6 hours ago." And I was like, "I need to, come with me." And we were talking on the elevator, and they remember talking to him. And the kid ended up dying, and it's a horrible story. And this is an epidural hematoma is something that if you have and you identify and diagnose quickly or appropriately, you can take them to the OR and they'll be home in 2 or 3 days. But on the reverse side, like Natasha Richardson, if you don't identify it, she's the actress several years ago who fell, similar kind of thing. Fell, passed out, woke up, said she's fine, and then she had, once her epidural created the increased pressure that then made her go into a coma, she was too far from any medical care to take care of her. And so an epidural hematoma is going to happen on number one, it's got to be a pretty significant hit to the head, direct blow to the head. And number two, they don't necessarily have to have that passing out and then waking up. So they don't have to be totally out, but certainly a direct blow to the head. And if there's any confusion involved, any headache, you want to keep an eye on them. Now, the thing that's going to be different from this as opposed to a concussion is in a concussion, their sensorium, so their level of alertness is going to be the same, okay? So a concussed patient, has anybody not seen a concussed patient? Okay. So that they're going to be frequently needing reorientation. They'll ask the same question over and over and over again. That's not an epidural hematoma. The patient with the epidural hematoma will actually potentially come to, but there'll be a point where they start to get sleepy, and they'll literally start falling asleep in front of you. And so the differentiation of the epidural and the concussion, the epidural patient is going to be having a declining in their level of awakeness, okay? So some of you feel like that right now, but that's because I'm boring you. But if you see that patient and you're talking to them and they're just you're needing to not reorient them in terms of what they understand, but you're needing to reorient them because they're falling asleep in front of you, that's the patient you need to get to the hospital, okay? And so is everybody clear on that? So the concussed patient doesn't need to be woken up and this is the bad guy. So this is the wolf, like when you think of king snakes and coral snakes, that's the way I think of concussions and the epidurals. So this obviously is the coral snake. And so this unfortunately was shown that my kids were like, "Oh gosh, did you do that?" And I was, "No, unfortunately this is a post-mortem examination. We don't usually take the entire skull off, but that's what an epidural looks like." And so I wanted to bring this to everybody's attention. I'm wanting out time. Recently, the new pediatric guidelines for head injury were released. And this author affiliation actually goes down. There's like 2 pages of these people. And basically there's no changes in what the guidelines were from 2005. And they looked at things like increased intracranial pressure management, hyperventilation, mannitol usage, hypothermia, all those things, and there were no substantial changes. So nothing new to report. Again, age-related differences in neurobiology. And so the 5-year-old is different than the 10-year-old, is different than the adolescent. And that's something that we're trying to get a handle on with regards to what does that mean to the patient with the head injury, and are there any age-specific changes that we need to make to our treatment. Again, here's the brain maturing. These images were taken out of those sequences in which we were able to identify that change in the blood flow to the brain, which really is a remarkable thing, and that was discovered here by one of my colleagues. And so in conclusion, these are my two boys wrestling. That's a bad head. But take an active role in your patient's sports, in your kids' sports. Talk to their coaches rather. Talk to the other parents. Make sure that head injury is something that they're at least aware of, and that they can identify. You know, that again, we're in the process of changing the culture of sports, which means that we're diagnosing more and more head injuries. Don't be afraid to ask somebody for help. So if you just, you know, I tell people if you're sitting there thinking, gosh, what did he say about epidurals? You know, is it red on black or red on yellow? No, that's the snake. Don't be afraid to ask. Don't be afraid to send the patient to the emergency room. Let us evaluate them at all. If you're confident, great. But if, you know, it's far better to ask for help and get the kid checked out by just another set of eyes. I can tell you, I mean, it's hard. You know, I go around talking about concussion. I've collected research money on concussion. Some people say that I know something about concussion, and I'm sitting there looking at my kid on the sideline. I'm like, oh my gosh. All right, John, stand on one leg, you know. I start going through the whole thing. But it's hard, so I'll be the first to tell you that. If in doubt, make the kids sit out, school and sports. Any headaches, anything, just tell them to chill out. If they're still having headaches, they come back and see you. You really need to pry hard. So that's another thing. You'll send them home. You'll tell them all these things. Don't do this, 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 and this. They'll come back. Yes, I'm still having headaches. I don't think I can go to school. What have you been doing all day? Well, I've been playing, you know, whatever that is, Minecraft or World of, you know, all those crazy games. They can't do that. And then finally encourage wearing a well-fitting buckled helmet on anything with wheels. Any questions? That's a great question. As soon as they're headache free, yeah. So that may, okay, sorry, yeah. And I was told to repeat the question. So the question was, after a concussion, what is the return to playing a blowing instrument? Are there any guidelines or any recommendations on that? I would say, again, treat them as if they're going back to school. So once they're headache free, then they can go back to school, they can play the instrument. If that does precipitate a headache, I would tell them to wait a week. And that does happen, actually, usually more in brass.
You briefly mentioned the biomarkers,
Mm-hmm.
which obviously would be objective measurements. And
Correct.
Do you have insight to the time frame you think we'll have a marker we can say normalize?
Yeah, so a friend of mine actually at WashU is working on this, and he's been looking. He's actually isolated a few things that he wants it to be a urine test. So you'll come into the emergency room, they'll take a urine sample, and they'll be able to identify brain injury. And there are a few, actually several available, serum and urine, proteins that are elevated or decreased in head injury. The problem is that there's other injuries that make these same things raise and lower. But I'd say hopefully within 5 years.
Another question, part two.
Mm-hmm.
So there's not a lot of neurosurgeons in the world, and there's a lot of community that have athletics that are outside the major metropolitan areas.
Mm-hmm.
It seems like they're certifying cohort of physicians. In other words, you know what they're saying.
Right.
The lifestyle thought is great. The problem is any doc can say, hey, go back.
Right.
You don't have to follow the process. Is there movement on that nationally?
That's a great question. So the question was, is there movement on certifying physicians to take care? And that's the truth. So who takes care of head injury? And that's something that organized neurosurgery has wrestled with. I've actually stood in a room twice this big with all the pediatric neurosurgeons, and we've debated this. You know, do we want to take charge of it? Is it the pediatricians? Is it the neurologists? And right now you've got all these groups. You know, that group in Prague that got together to try to define concussions was serious. There were probably 12 different specialties there. Orthopedic surgeons, you know, take care of concussions in some communities. And I can just say over the last 5 years, it's gotten better. But, you know, one of my colleagues, one of the guys who trained me, who's now not awake anymore, but he didn't want to ever see a concussion. And he'd say, just go to your pediatrician. And I'd always say, pediatricians don't, they're not into this. Now, pediatricians now are. And pediatricians are far better, I think, than the majority of neurosurgeons now because it's part of their training and they learn about it. But no, there's not at this moment. It's just people who take a personal interest in it and kind of seek it out and try to get the referrals, fortunately.
Is there any new data about use of the CT on all head injuries? In children, there used to be a talk about you should have so many CTs in one lifetime, because of radiation. I'm wondering, have you established for ER doctors, with the defensive practice being in mind, a gold standard?
Right. So the question is there any data on the number of CAT scans that is safe to have? And I would say as few as possible. So there's a study that was released, it's within the year, it's out of Great Britain that looked at that and looked at rates of radiation-induced tumors, intracranial tumors, so things like meningiomas. And they were higher, obviously they're higher the number of CTs, but that threshold has not been determined. And certainly, if one CAT scan could potentially put you at risk. And that, we use things like MRIs now to evaluate shunt malfunctions and things, but no, I don't have a number for you.
Younger children, toddlers to preschool age, who can't necessarily communicate in a way that you can ascertain
Right.
their level of consciousness or their ability to communicate. Do they have a protective mechanism? I mean, I'm thinking about toddlers, and I interviewed who had horrible falls and bumped into everything and goose eggs. Do they have a protective mechanism, or are there things we need to look out for?
Yeah, so the question is, do toddlers have a different threshold for concussion, or do they have a protective mechanism or anything like that? And the answer is no, not that I know of. And I'll tell you, the hardest hits I've seen, my middle child, he's like always hits his head. But I think his head's like an anvil. I mean, really. And that's true. I mean, if you look at the boxing literature, I mean, some guys can take a hit and some guys can't. And those of us that are in this business, we talk about it, and it's likely due to the thickness of their skull. Some guys, they're certainly players in different sports who are more susceptible than others to concussions. Again, once you get that first concussion, it's easier to get subsequent ones. But there is definitely a difference, and it's not. There's probably a brain difference, but it also probably has to do with the musculature of your neck, the size of the bones in your face. And so, those boxers that could really take a punch, there was probably a reason for it.
Can you talk about the neurometabolic changes? Are there drugs that are being researched for the glutamate prescriptions?
There are, and nothing has, there's NMDA agonists that have been looked at, but there are. The question was, are there drugs that are being researched to help with, I guess, with brain injury and decrease in symptoms? There are, but nothing has stuck. Yeah, we're kind of far away from that because we don't know what's happening, and that's the. Yeah, and I will bet that the type of injury obviously is very heterogeneous. It's not just one thing. So there's axonal damage, there's local contusion within the neurons versus the axons, and how that there's blood flow changes. Are there connections between the cells? Are those being disrupted? Are they just being slowed down? We don't know.
Is there any data
Any data with regards to what? Mm-hmm. No. Now that's never been done. I think you'd ethically have a problem doing that because you'd obviously have to. Now there are studies in rats that have been done, and yes, there are protein elevations with head injury, brain injury in rats. But in order to do that, ethically, I don't think we could do that on humans just to collect the spinal fluid to identify that. But yes, that's the best place to get biomarkers is the spinal fluid, and that they have been shown. Yes.
I was curious if there's, obviously, there's lifetime concussions symptoms, but with someone who gets one random concussion throughout their life that's fairly bad,
Right.
moderate, mild or moderate, can they have continued symptoms throughout their life?
Yes. Yeah. So the question is, can one concussion give symptoms for a lifetime? And the answer is yes, and that's why we don't use that mild to moderate thing. So if you three fall and hit your head or run into somebody, and you pass out for a minute, you don't pass out, and you pass out for 2 minutes and have a seizure, which one is worse? Well, from the outset, we'd say that hers is worse because she was out longer and had a post-concussive seizure. But none of those things actually predict how long you're going to have symptoms and what type of symptoms you're going to have. And so that's the difficulty in these grading scales. And one concussion certainly can have it. And now, I told you about the kid in Greensboro that couldn't read. He actually began speaking like he was a 3-year-old. It was dramatic. And that was just something that I couldn't say anything to the parents except this will get better. And it did, but it took 3 months. And, is he more likely to have problems down the road than somebody else? I don't know. But it'll be interesting to see. Right now, I would say yes. I think, and is that, again, that CTE thing, was it just one hit that was hit a particular way or is it, a series of hits? Is it a series of hits when you're a teenager? Is it a series of hits when you're in college? We don't know. One more thing I would add that I don't think it's the NFL. The NFL is very suspicious of the work that we're doing here, and they kind of, I can tell you the doctors that work with the NFL are very interested in seeing, but publicly, as NFL people, they say, no, you guys are doing bad work because there's a big class action lawsuit between the NFL's Players Association and the NFL. But I think that they, I've told them this. I said, you guys should support our work because I think what we'll find is that maybe the exposure earlier on has created problems, not just that exposure as an adult when you're playing the NFL. All right. Thank you.
That reminds me, all of the lectures will be available online afterwards. We're going to do our best to link it up with the PowerPoint, so just be patient with us. It might not be today. We'll get that for you. And then I have cards on the printer table, so if you can't find Dr. Powers' email or any of the other speakers, feel free to email me and I'll get you hooked up. We've been asked to let you know